Thank you very much. Thanks. And lovely to be here in front of you, for those of you in the room and online. So we've been in a position for quite a long time where the kind of behavioural support could be for helping people quit smoking, or could be for any other kind of behaviour change, or actually quite a lot of other health and medical applications. We've been in a position where the technology can do things humans can't do anymore, not realistically. But it's taken us a long time to even get close to realizing the potential of digital approaches. So what I'm going to do is I'm going to cover a few areas in some depth, rather than cover loads of areas, around sort of opportunities for smoking cessation apps. Although I often think a bit beyond apps to digital systems, but usually the experience from the user is through some sort of app. And also talk about some of the competing challenges of achieving this and making best use of this technology. And some of those challenges are related to doing the research on these kinds of approaches, and some of the challenges are the actual technologies themselves, which I'm sure those of you that have worked in digital health are very familiar with. It's a challenging area, but one with potential high reward. So just, okay, we're good. So yeah, opportunities and challenges. We'll start with some opportunities. And one thing I think it's very hard to not talk about when talking about the potential for improving and enhancing support using digital approaches is tailoring. Maybe because have been interested in tailoring for a long time, but I struggle to not see tailoring in most of these new applications to improve the effectiveness of digital support. And I think of tailoring, which would be making support specific to the individual and individualizing it. I think of this in terms of two dimensions. So we've got the kind of reactivity of tailoring dimension from left to right. And we would start with, on the left-hand side, tailoring that's static, that's not going to change throughout a behavioral program or a smoking cessation program, but it could be tailored according to lots of different characteristics, things about the individual, their background, their characteristics. Could be things to do with their smoking dependence, or kind of what you might call clinical characteristics, all the way up to their beliefs and their actual behavior as well. But the point is, these would be fixed in time, and then the program would it be adapted to those characteristics. But an important point I think we all would both recognize in our own lives and probably in our research is that people don't stay still on a lot of these things. So demographics and social characteristics, those things generally do stay the same. But people's experiences, people's behavior, people's beliefs, even their motivation, these things wane and change over time, depending upon what's happening. So if you make an intervention dynamic, then you can adapt to these changing factors, and these might be some of the same things as you might tailor to static factors, but you can start to move to a point where you actually are able to measure transitory aspects of their lives. So it might be their current emotional state, which is really predictive for some behaviors, or their current context in a given moment. These things undoubtedly affect our behavior, make us more or less able to stick with a change or make a change. And the technology is certainly there to support tailoring to these sorts of things. But it does come with some challenges. There is some evidence that interventions in general that have dynamic tailoring are a little bit more effective than those that have static tailoring. I think that would make sense. They can be a bit more adaptive to what's relevant to that person as they go through, in this case, their quitting journey, but it could be the same for any behavior change or other aspect. And probably at the moment, the most kind of dynamic tailored support. Or one of them is AI chatbots. No doubt we're seeing them everywhere, being pushed to us when we're not even sure if we really need them or want them. And they'll increasingly feature in medical and health applications. And so it's important for us to understand where they fit in and how we can maximize their benefit. I'll talk a bit about chatbots in a moment. There is some evidence that chatbots can change behavior on their own. And I'll dig a little bit into the evidence for that with smoking specifically. Okay, so that's the sort of reactivity dimension. Then we've got the slightly harder to get your head around causal model that underpins the support that's provided. So let me explain what I mean by this. So you can have support that has an assumption that people are all the same, and that the things that drive them, the things that influence their behavior, are equally the same. A bit like a lot of theories, they don't specify how different individuals might relate to the theoretical constructs. They suggest that certain constructs influence another construct, and that would be the same across people. Or it might be that you have a subgroup of people who works a bit differently, but you'd still be basing your underlying or underpinning model on some kind of aggregated belief in what's happening. So it could be as much as your estimate as a clinician or an expert in the area. Could be based on theory, as I mentioned. Could be based on you could have had lots of data and trying to identify what those determinants or those influences are on behavior. But ultimately, you'll be aggregating them together. You'll be missing a lot of the variation because you're sort of averaging things together. I'm not saying that's good or bad, but that's just one way of doing it. On the opposite end of the spectrum, you'd have a model which is completely individualized, so that it's targeting factors that influence your behavior or an individual's behavior, not everyone else's, but what's relevant and important to you. And this could be based equally on frequency data, but that would be specific to an individual. You could be doing statistical analysis on that individual's data, and we do a lot of single case design studies where we might try to get enough data for one person to really understand what drives that person, what things we might want to target in an intervention. Or you can do things like computational modeling, where you input different characteristics, and the model will kind of indicate, based on those, what that individual might need. Or go as far as using machine learning or other kinds of artificial intelligence approaches to individualize the support that's provided. I will talk a bit about some of the challenges and opportunities around this as well. I would say that all things being equal, you probably want interventions to be in that top right quadrant if you could. So you'd probably want interventions to be tailored to what's important for an individual. You'd want it to be as dynamic as needed. But it's not. But it does come with challenges, and hopefully the examples I'll give will pull out a few of those challenges from our own experience. And if I get to speak to some of you, it'd be interesting to hear your challenges too, perhaps over the next day or so. That would be really interesting. So let's just talk a bit about chatbots, as they're in our newspapers almost on a daily basis, or at least my feeds, and they're quite an interesting approach. So this is kind of what I've learned so far about chatbots for smoking cessation. There's two ways of developing them. That's the first thing I've learned. You can do it slowly, carefully, and systematically, or you can go quite fast. There's already quite a lot of off-the-shelf large language models that do a surprisingly good job just from asking them some bits of advice. So I'm going to give some examples of the slow and the fast method. I'm not saying which one's better or worse in the same way as I mentioned earlier about the tailoring dimensions, but they are different ways. I think each have their challenges. So you'd probably have to have been hibernating not to know these days what a chatbot is, probably, but they're largely can be split into two different types. The older generation are more of the sort of rule-based ones, or they might use some natural language processing, but lack the the real kind of interaction sense that you get with a generative AI or a free flow chatbot. And with the sort of step change we've seen in chatbots, these are the most common ones now. They're generally mostly text-based, but they can use audio and video. And I think audio-wise, we're going to be seeing more of this in the next few years, particularly in smart speakers, for example. I think there'll be a big change in that relatively soon. So, broadly speaking, chatbots have been researched for a while. They have been around for a while, but the more sophisticated ones more recently. People report that they give them space to think without interruption. And this is specific to smoking and a bit broader as well. There's that immediate feedback they can get from it. They trust the information that it's giving, which is both good and bad, because as I think we all know, the accuracy of some of the information that some chatbots give is not always high. But importantly, I think this is one of its superpowers, easy to read, and people really find it quite easy to follow what chatbots say. It's very good at speaking in lay terms. And I think that's definitely a strength. And there's people do like the fact that the chatbots have the potential to reach out to them. And I think in terms of smoking cessation support, that's going to be a really important one. Actually having your personal chatbot counsellor who can reach out to you. That feels very different to some of the other kinds of support. But there are a number of issues, which I'm sure we're all familiar with, privacy issues, and I think a lot of people don't realise what's happening to information they're putting into a lot of chatbots. That's a concern. People often don't know, even people working with certain chatbots or large language models don't quite know what's happening to the data, even when they say it's not going to the mothership. Often it seems to be, some of it is. There's also a user burden typing. Whether it's on a phone or keyboard, that's a factor. More effortful potentially than talking. Interoperability with other systems, and big one, bias. I'm not going to really talk about that, but we know that these large language models in particular are fed on all kinds of data which have big inherent biases in them. So in turn, these will be biased systems. So what do we know about chatbots so far? So there has been a review, and I haven't found an updated review, so it's a few years old, and it's primarily based on rule-based chatbots. So these are the kind of like version 1.0, I suppose you could say, if large language models are 2.0. Even so, and in this particular review, there was a meta-analysis of 3 of the 5 trials that they looked at. And when I first looked at this, I thought, okay, this is looking quite interesting. The effect sizes suggest some benefit of the chatbot over the comparators. But I suspected before actually looking at the papers, but the comparators are probably pretty weak and, no interventions. I was really surprised at the intensity of some of the comparators, including face-to-face stop smoking support with pharmacotherapy in 2 of the cases. Early indications certainly suggest that there's definitely something in chatbots. There's no reason to think there wouldn't be, but it's certainly encouraging early evidence. And one of the studies that weren't included is a rule-based chatbot embedded in the Smoke-Free app, which also found increased engagement and cessation. So all in all, some pretty encouraging early evidence there. And then this is the sort of 1.0 version of chatbots. So one would expect that more sophisticated chatbots would be more effective, but not necessarily. So here's an example of a slow and careful developed intervention. This is developed by Jonathan Bricker and colleagues in the US. I think this is an incredible amount of work published in this one paper. If you ever look at it, it's so many things. It even includes a randomized controlled trial within it. It's lots of co-development, very careful work. But the timing of this project, I feel really shouldn't say I feel sorry for Jonathan because he's a fantastic researcher, and but I think the timing of this particular project was just before generative AI really kicked off, and I wonder what it would look like if this project was done maybe 2 or 3 years later. Probably very different. So this was using kind of good old-fashioned natural language processing, and it basically delivers stop smoking support in 2 to 3 minute structured clinical conversations. It is quite structured. You can see an example up there. And they had this big database of answers to questions that people could pose. And so they were using that approach for answering questions. In terms of what they found, they had sort of mixed evidence of benefit. So there were some indications, positive indications that compared to a text message system providing stop smoking support in the US, the QuickBot, which is their chatbot, which you can download actually, it's available, so you can download for free if you're interested, found increased engagement, but no difference in 30-day abstinence 3 months later. But interestingly, they did a sort of engagement analysis where they looked at people who were really engaged in the chatbot. They seem to do quite well. It's always very difficult to disentangle whether they're the people who are engaged because they're doing well, or is it the engagement that's making them doing well? And we're not going to resolve that one. But one issue that came up was that some participants expressed frustration that it wasn't very good at answering their questions. And I think this one's going to be resolved with, and I think it is resolved already with generative AI, which is very good at answering questions. In fact, almost too good because it keeps asking more questions. It's just kind of default option is to finish its bit of text with a question to you to keep you talking. So it's a funny quirk. So that's an interesting one, and that was over a long period of time. They have now integrated some generative AI into it, I think, for the question element, but it's still largely not a generative AI experience. And then a fast way of going is a colleague, Lorien Abrams, in Washington, who basically took a very fast approach and said, okay, well, let's see what ChatGPT off the shelf can do with a bit of prompt engineering, and let's see how well it adheres to public health guidelines, and compared it to a couple of other chatbots. And interestingly, it did surprisingly well, given that it was a fairly quick kind of process, but had the same issues as you might have experienced yourself when you're using a chatbot. So just this nice quote here: while chatbots reliably provided some types of information, they omitted other types, as well as occasionally providing misinformation. And that sort of sums up, I think, some of the issues with chatbots in general, especially for queries about less evidence-based methods of quitting. So Lorien and colleagues have been refining and improving this approach, and are using an approach that we're also using, where you basically have a database of information and you tell it, you want it to prioritize all the information in that database which you control. So it's a way of reducing the risk of it providing misinformation. A RAG database, as it's called, retrieval augmentation generative, something to do with generating. After a while, people just call it RAG, and then you stop working out what it means. And interestingly, Lorien and Jonathan and myself are talking about chatbots in a seminar, an online seminar. If anyone's interested, then we're talking about our respective chatbots, including some other people as well. So yeah, we're really trying to create I kind of like to think of it as a bit of a self-help group, really, when working with these things, to try and work out how we might improve and learn from each other to that. And this is hosted by the Society for Research on Nicotine Tobacco in Europe. So I wanted to just pull out a few bits of, sort of dig in a little bit into people's experiences of a chatbot, to pull out some of the pros and cons. So this is based on that smoke-free chatbot I mentioned earlier. So I'm just going to pull out a couple of things which I think are interesting in terms of learning how we can adapt and use these for good. So people who used them, and this is a rule-based approach, they said that they felt that the chatbot promoted feelings of accountability. Now, when we started a particular project, which I'll mention in a bit, we were a bit worried that no one would feel any accountability to a machine, essentially. But interestingly, people do seem to apply kind of, I suppose it's anthropomorphism, sort of, some accountability or for the chatbot. So it cared about whether I was smoking or not. I wanted to find an opportunity to make it happy. It's really nice to see. People also felt that it was superior to sort of friends and family. And I think there's a couple of things I've pulled out here. So immediate availability, that's one key thing. We know that it's always there whenever you want it. And non-judgmental. You can ask it anything. It's not going to judge you. In fact, it's very good at not being judgy at all. And the other thing that came up from this was it was one way. It's a sort of, you didn't have to reciprocate in the relationship. Unlike if you maybe reached out to a friend, you might feel you needed to do something for them or what have you. We might feel bad at asking them to do things. So these are some interesting characteristics that I think if people are using it therapeutically, and maybe why we're hearing about people organically using chatbots therapeutically because of some of these kinds of factors. However, and this may be specific to rule-based chatbots, a lot of people felt that forced choice interactions got boring quite quickly. As you can see from this quote, a bit samey. People also were a bit frustrated that it felt like the chatbot had some kind of amnesia in that when they sometimes came back, they were starting conversations afresh, and that there wasn't much memory as to prior conversations. Now, interestingly, those two things I think can again be addressed with large language models or generative AI-based chatbots or chatbot systems, which really technically they are because they're more than just one large language model these days. Particularly this memory thing, and in chatbot we're developing at the moment, we are able to in this database that we're telling it to use as its source of information, we can give it all the past chat history, as you're probably experiencing with other chatbots you might interact with, and that's really quite powerful because it can remember things that you've said or said you were doing. How did it go when you went to that wedding? Did you find it difficult not to smoke with your old smoking buddies, whatever? Those sorts of, I'm not saying that's a great example, but being able to sort of report back as a potential strength. So I'm not going to talk much about what we're doing, partly because it's in development at the moment. What we're trying to do is combine the best of, well, hopefully the best of both worlds, is to have some element of, so I should give you a bit more information about this project. This is a project looking at providing an online stop smoking support for people who are pregnant in the UK. And we're trying to convert what's currently delivered by humans and counsellors into a fully remote and automated package, but without losing the counselling, the protocolized counselling that we have called the standard treatment program. And so to do it, we're building a sort of element of some degree of rule-based, and it may be that actually it's not going to exactly deliver exactly as we have written it, but pretty much certainly in terms of meaning, but it might slightly adapt it in its own voice. I'm talking about the generative element of it. But the key thing is that we'll have generative AI feel to it, and all the questions, all the interactions is powered by generative AI. So it will feel like that kind of personal interaction. I'm talking about our aims here. I'm not saying it does yet. It turns out it's really quite complex to develop one of these systems. And there are multiple chatbots within it, multiple large language models that kind of check each other's homework, as you might say, and lots going on. But One thing we found out, though, when we did lots of development work, speaking to the populations, experts, people with lived experience, is that they still wanted there to be some way in which they can get hold of a person, a human. So we're still having a human escalation option, and we're going to see how much people use it. We're not going to sort of promote it as a way, or you can use this. It's going to be if there's something that isn't being answered, or you're worried about, or you really want a human to respond. And particularly because it's about, quitting smoking in pregnancy, there may be some specific pregnancy related queries, then there'll be that human element there in a kind of asynchronous chat. I'll talk a little bit more about that tomorrow for those of you that may be there. Okay, so that was chatbots, and I'm going to talk a bit about just-in-time adaptive interventions. Going back to this two-dimension kind of tailoring grid, you could perhaps think of them as being anywhere probably on the right of this side, always pretty much dynamic, or it should be. And it can go from, having an underpinning model that's based on groups all the way up to an individual. If you're not familiar with a just-in-time adaptive intervention, then you're in good company. Actually, it's quite hard to define. We spent some time trying to define it and have tweaked and adapted this definition a few times. So it's basically an intervention that corresponds to a need in real time for some sort of support. And that could be a vulnerability where someone might be at risk of doing something that they don't want to do, it's against their goals, or it could be an opportunity where they could do something positive to achieve a goal. The key thing is that the content of that support is adapted to that real-time need or opportunity in some way, to the timing of it and what is going on for that person, what's relevant at that particular time, which is why context is a very valuable bit of data. If you can know what's happening for someone at that time, then you can perhaps do a better job of giving the right kind of support that matches that. So I'm going to give you an example. So we've split up just-in-time adaptive interventions into two main types. There's the active type, where it's kind of user-triggered. And an example of that is a system developed by Michael Bussenell and Emily Herbert and colleagues called Smart T2. There was a Smart T1, but this is Smart T2. And this basically triggers the support based on ecological momentary assessment surveys, or EMAs, that are sent at specific times of day based on an algorithm. And it's assessing people's kind of real-time urges, stress, drinking, the presence of other smokers, their motivation at that time, and whether they have cigarettes available. And then it decides on whether support is needed or not, based on, what the risk is based on these things. And then if a threshold is reached, then support is delivered based on that. But it's user triggered in that the user has to complete that EMA for it to deliver the support. And then another example of that is an app that we developed called QuitSense, which is a passive system. So people don't have to do anything to activate the support. They do have to train it at the beginning. But once they start a quit attempt, it senses their location and it bases and it uses the information it's learned about each location's triggers and their urges, stress, mood, presence of other smokers, and what that location means. Is it a workplace? Is it socializing places at your home? And then adapts the support and the support is triggered in real time based on their location, and it's adapted to those triggers in that place. So active and passive. Most in the addiction field, so if you look at addiction behavior, just-in-time adaptive interventions, as we did, led by Olga Persky, most of the JITIs that are around are these active type where people have to engage with them. I think there are pros and cons with each of these different types. Again, not saying one's better than the other. And again, it probably depends on the population as well. So just having a little bit more of a look at our QuitSense app, I'd sort of hopefully explained the main concept. And just to say, with all these projects, it's a big team of people whose expertise and hard work has made all these projects possible. I'm just representing the team. And the Quit Sense as an app works across 3 different stages. I mentioned before it needs to be pre-trained, so people would set a quit date, and then all they're asked to do is to report smoking every time they smoke, and what the triggers are each time they smoke. So they complete a survey, and for example, that second screenshot there is looking at capturing urges. And then after they've completed that for each time they smoked, they get some feedback and some sort of preparation advice. And they can also get that data back from the app, summarized in different ways. And that works until their quit date arrives and they start their quit attempt. And when each report is given, as well as the self-reported data, it takes a location snapshot and works out where they are, what's that location. And it remembers that and creates a virtual perimeter or a geofence around that area so that it knows this is a smoking location and these are the kinds of triggers, and it averages out those triggers for that individual in that location and what that place is. So that when your quit date arrives, it knows if you've entered your home zone, which might be a high-risk place because you've smoked in the past there, you'll be cued to smoke based on whatever the cues are that hopefully have been captured, and then it'll adapt the support it provides based on those factors. So if stress has been reported a lot when smoking at home, then it's more likely to deliver stress management advice and so on. So it adapts, tries to make the advice relevant to what the cue or trigger might be in that location when you're in that location. Okay, so just a couple of points to pull out here. Again, there'll be some other aspects of that project I'll talk about tomorrow. One key thing is, can we actually intervene quickly in real time? Do people, we can test that, and then if we do people then engage with that? Because if they're not engaging quickly, then actually maybe we need to rethink how we're doing things. So in this sort of analysis, and this was only based on quite a small number of people, in one of the early studies, one thing we learned is that the messages that were geofence triggered, that people got in locations, people actually reviewed them pretty quickly, an average of a median of about 5 minutes. And most 80% of messages were viewed within 30 minutes. And we compared them to sort of some more static, well, not static, but scheduled support messages that were delivered by the app, and actually found that people were a bit slower to respond to those. There is reasons why there may be some differences there. It could be to do with timing, or could just be to do with how people engage with phones. But the key thing is that people do respond to messages pretty quickly. And so I think that certainly seems to address for our app that question of will people engage quickly. Interestingly, though, they didn't engage quicker or slower whether they're at home or at work. So, we can still learn about this, but generally people responded about as quickly where they were. And this maps onto other studies that found most messages, somewhere around 80%, seem to be viewed within about 30 minutes, looking at some other kinds of studies using some similar approaches. Final opportunity, I'm mindful of the time, is mobile sensing. So using other sensors. So we've used location sensing, but there's a whole raft of different sensors that could be used and are being explored. I just wanted to mention one in particular. So one sensor is looking at gesture recognition. So being able to capture smoking behavior using a smartwatch and using some software based on that. And some colleagues at the University of Bristol have been doing some great work around this. And we're trying to look at exploring the measurement of other behaviors using similar technology, because it seems to be quite good at actually detecting smoking behavior and actually looking at it for alcohol consumption as well. And combining, automatic, passive sort of measurement with passive-based sort of delivery of support, you can get potentially quite a sophisticated system. I'm not going to mention it today, but tomorrow I will mention some of the downsides of that, which we learned the hard way around passive measurement. I'll come on to that then. It's a bit unfair to talk about things we could talk about tomorrow. So just to cover a few of the challenges, we've got to remember that humans have been communicating with each other for thousands of years. We're pretty good at it. There's always some room for optimization. But how we communicate with technology, that's something we're still learning on. It's still relatively recently that we've had smartphones, and there's got a lot to learn. And so I think this is definitely one of those challenges. The technology changes as well as people. So we will change, and we are changing rapidly how we engage with things, but the technology does change quite quickly, and that presents a real challenge with digital health. If you're going to use it off the shelf or any third-party product, they change things, they stop things, they go bust. I've got examples of all of those from people I've spoken to where they've spent months and months investing in a particular wearable, and then that wearable company goes bust, or they change the actual product, and suddenly all of that work is not necessarily completely wasted, but needs a lot of work to get back on. When you develop your own intervention, sometimes the sort of digital infrastructure changes. So, for example, the Google Play had part-way through, well, we were just about to start a randomized control trial, and suddenly there's a location, a change in the privacy policy that was needed for every app on how they collect location data. And so we had to kind of quite quickly change this and implement this within the app. And obviously sort of worried about if users click on no, QuitSense can't use my location, then the app doesn't, that's its main kind of USP. So yeah, it can be quite challenging. And maintaining that app for a long time. I think, and I mentioned it briefly earlier, if you're going to evaluate when you're generating evidence, what do you compare it to? And we kind of always knew this along the way, but Janice Crace and Moraine de Bruin and colleagues did really, really important work looking at what impact the comparator has on the effect size. And they went back to lots of interventions and through some clever approaches, sort of were able to simulate what would happen if different interventions were compared to different kinds of comparators. And the key thing is that, as we kind of knew all along, but we're maybe burying our heads in the sand, it makes quite a big difference to how effective or not effective your intervention is based on what it's compared to. And that makes it difficult, because you might want to compare an app to something that's an actual other app, because you want to demonstrate to the academic community, to the people who might implement something, that it does better than something that already exists, or that some kind of active control. But in reality, is that going to be a real comparator in the real world if someone uses your app? Well, I don't know. That's it's not always very well matched between the real world and what's used as a comparator in a study. And then learning about which components or messages work best, and for whom, and where. And these are some of the big challenges that we have. Saying that, I think there's a real opportunity. So I'm sort of switching back to opportunities here, because there are some really interesting methodologies that can help us to learn about this, which we wouldn't be able to do in, say, counselling delivered or other kinds of modes of delivery. For example, for those of you into methodology, you might be familiar or very familiar with the multi-phase optimization strategy. One of the elements of that is doing things like factorial studies, and here's an example of one led by some colleagues at UCL, looking at a factorial randomized experiment. Here they had 5 different factors or conditions, well, not conditions, different elements or components they were testing out that were either switched on or off, and they ended up with 32 different groups in terms of ons and offs. And so this can be a very good way of exploring what might be the most useful and active components of intervention. It's also very complex and can be difficult to interpret as well. So it has its own sort of drawbacks. Another approach are looking at micro-randomized trials, where individuals at any given point, or well, actually in this case, triggered by a specific point might be randomized to receive either a in this case in this study a cognitive behavioral therapy based message, or a mindfulness or acceptance and commitment therapy message, or a control message. And this is determined randomly multiple times a day across a period of time. And then after that's been delivered, an EMA is sent to measure some key factors to see what's the impact of those different messages. And because it's randomized within the person, then you're able to have stronger kind of inferences can be made about what might be the most promising approach. And then finally, just to highlight that engagement is a big challenge with apps, and this can lead us to thinking sometimes the simple approaches sometimes have advantages. So we have a text message based stop smoking program for, again, smoking and pregnancy, and we find very good engagement. So we have 81% of people report reading all of the messages pushed to them over 12 weeks, which is around 11, don't know where that came from, 100, although not a huge amount of people request on demand support. That's something else we learned. And then a really well developed app, which we saw in that factorial study a few slides before. This was again for pregnancy, but really low engagement, a mean number of logins of 2.9 times. People only engaged for about 4.5 days on average, and then the highest feature engagement was less than a third. So it just demonstrates that sometimes the stuff that comes to you is nice and easy, simple, can drive greater amounts of engagement. And we really need to think about how we promote engagement on smoking cessation apps. I've highlighted here some of the areas that both of these, well, through a sort of cross and tick approach, which of these two different interventions use them. And the ones with a little box around them are ones that a review that Dorothy Sinoy led showed that are associated with increased engagement. So things like well-designed reminders, which text messaging does very well because it's all reminders basically, or prompts. Things like low cognitive load, ease of use, personalization, those factors are important for driving engagement. And it may be that they have something to do with that difference in engagement rate. I think I'll probably best stop there. That I will, I'll end on that nice picture of a desert. I was going to make a point about data sparsity, but I'll squeeze that into tomorrow. Thanks very much for listening.
Let's